My name is Horst Sievert from the Cardiovascular Center Frankfurt, and I would like to discuss with you the results of the CHAMPION-AF trial, which is a trial comparing LAA closure versus DOAC, and I especially want to discuss what this means for our daily practice. So let me start with the key results of this study, because CHAMPION-AF met actually all endpoints, and these endpoints included the primary efficacy endpoint, where non-inferiority was tested, and this was a combined endpoint of cardiovascular death, stroke, and systemic embolism. And there was a second primary endpoint, which was a safety endpoint, where superiority was met, and this is non-procedural bleeding. So the secondary endpoint had been any major bleeding, including procedural bleeding, where LAA closure was non-inferior to DOACs, and there was also a secondary endpoint defined as net clinical benefit, and this included a number of parameters as listed on this slide here. And in this endpoint, LAA closure was superior to DOACs. Well, as always, interpretation is key. Let's go through the details of this trial. Background of CHAMPION-AF is that LAA, left atrial appendage closure, is considered for atrial fibrillation patients who are unsuitable for long-term anticoagulation. That's currently in the guidelines, but its role in patients who are eligible for anticoagulants, it's not clear yet. And the methods of that trial: 3,000 patients with atrial fibrillation suitable for anticoagulation. Mean age was 72 years, 32% of the patients were women. Mean CHAS-VAS score was 3.5, so a broad AFib patient population. Randomized to left atrial appendage closure or NOACs. Primary efficacy endpoint was a composite of death from cardiovascular causes, stroke, or systemic embolism, tested for non-inferiority. Primary safety endpoint was non-procedural related bleeding, tested for superiority. Let's look at the results. At 3 years, the primary efficacy endpoint event had occurred in 5.7% in the device group and in 4.8% in the anticoagulation group, and that was a p-value of 0.011 for non-inferiority. And non-procedural related bleeding occurred in 10.9% in the device group versus 90% in the anticoagulation group, and that was a p-value of 0.001 for superiority. Conclusions of this trial: among patients with atrial fibrillation who were candidates for anticoagulation, device-based left atrial appendage closure was non-inferior to NOAC with respect to a composite of death from cardiovascular cause, stroke, or systemic embolism, and was superior to NOAC therapy for non-procedural related bleeding at 3 years. So again, overall, this is clearly a positive trial, but it's not an easy one. So what are the critical issues of this trial? There's a stroke signal, numerically higher in the left atrial appendage arm. Procedural bleeding was not included in the primary endpoint. The non-inferiority margin, maybe it was too wide, and the composite endpoint combines very different endpoints. Well, all these points are very valid and need to be considered. So let's go through this step by step. More strokes after LAA closure. Yes, after LAA closure, the stroke rate was 3.6% versus 2.5% under anticoagulation after 3 years. This is not unexpected. Anticoagulation works systemically, whereas LAA closure addresses one specific cause of stroke. Across all trials, the benefit of LAA closure consistently comes from reducing bleeding and not from reducing strokes. There was a bleeding trade-off. LAA closure resulted in a 45% reduction of non-procedural bleeding. That means gastrointestinal, cerebral, or DOAC-related bleeding. But if we include procedural bleeding, the difference becomes smaller. There was less reduction of overall bleeding. That means only 34% versus 45%. So we are trading a one-time procedural risk for a lifelong bleeding risk. And different patients will value this trade-off differently, of course. The non-inferiority margin is too wide. Yes, non-inferiority was met, but the margin is debated, and a wide margin allows for a certain loss of efficacy, and that is where opinions differ. So the question is not only was non-inferiority met, but how convincing it actually is. However, non-inferiority trials always depend on the chosen margin. This is not unique to CHAMPION-AF. Even with that margin, absolute event rates are low in both groups, and importantly, we are not combining two drugs, but we are combining two completely different treatment strategies. The composite endpoint combines very different endpoints. That's true. Death, stroke, or systemic embolism are not comparable, so the interpretation depends on what you value most. Yes, composite endpoints have limitations, but they reflect the overall clinical reality. Patients do not experience endpoints in isolation, and the composite endpoint always simplifies statistics, but always complicates interpretation. And this is not unique to this trial. So let's put this trial in context to other studies. There was the OPTION trial, which was published in 2024. The OPTION trial shows a similar signal in post-AF ablation patients. So we now have two independent trials pointing into the same direction. And then there was CLOSURE AF, which was published just recently in a higher risk population. LAA closure was inferior to anticoagulation, and lessons from CLOSURE AF had been patient selection is critical and procedural outcomes are important. Adherence is very important, and this is often underestimated. In the real world, only about half of patients are treated according to guidelines, and adherence is far from perfect. A DOAC that is not taken will not cause bleeding, but also it will not prevent a stroke. So efficacy in trials is not the same as effectiveness in real life. LAA closure works independent from adherence and lifelong. Why LAA closure moves forward? Despite these criticisms, there are strong arguments in favor of LAA closure: less long-term bleeding, independence from adherence, and patients' preference. Trials are controlled environments, but real-world patients behave differently, and that matters. The discussion in the future should not be LAA closure or DOAC. The discussion should be which strategy fits which patient. And we need a lifetime strategy. Timing really matters. Too early may expose patients to unnecessary procedural risk, and too late, and the patient may no longer benefit. The question is no longer should we close the LAA, the question is in whom and when. Champion AF shows that LAA closure is a reasonable alternative to anticoagulation. Thank you very much for your time.